Good evening, everybody. That's good. I like that. There you go. Perfect. Tonight's program is sponsored by Genentech, Sanofi, and TG Therapeutics. Let's give them all a round of applause and thank them for doing what they did. We can't possibly do our programs without the pharmaceutical industry supporting our programs. So we do thank them, and we thank all those that were here today to exhibit and show you their products, okay? Dr. Gold, if you don't know, he's a neurologist at Health First Medical Group in Melbourne.
We just got out of a pandemic, and we haven't done any in-person lectures, so I wanted to make sure we got to do something like this. This is, I appreciate Stuart asking me to do this because it gives us a little chance to talk about some of the things that we are near and dear to our hearts. So I wanted to provide a different perspective, and I've just passed my 41st year of practice, hard to believe, and I didn't realize it until I started talking about my training program in the 1970s and 80s, and everybody goes, wow. I go, yeah, I am getting there. And so I decided that I was going to give you a little bit of a perspective, kind of go back to what things were like back in the day and how far we've come. And I know you all are incredibly frustrated over the slow progress that seems to be made, but if you look back, you get a much different feel for where we've come and how far we've come and where we're going very rapidly, actually. So we're starting to make some pretty dramatic turnarounds. When I went to medical school, the only technology we had for imaging the brain was CAT scanning or CT scanning, computerized tomography, and that did nothing for elucidating what we see in MS. And I remember in medical school talking about MRIs and how they were coming, and we just thought that was a pipe dream. But when it came out into the 1980s, and we got to use this during our residency, which is in 80 to 83, we were just astounded by the quantum leap we had made over CAT scanning. And so that's really helped us for a lot of diseases, ruling out other things that might mimic MS, but also helping us to better define the disease and where we've come. So we'll talk about how some of the criteria have changed over time. When I was taught my neurology, we said, well, multiple sclerosis is pretty clearly a demyelinating disease. It's all in the white matter. And we think there's some inflammation involved, but we weren't really sure. We started talking about how the immune system in the body was acting to go into the nervous system across the blood-brain barrier and produce damage. But that was the extent of it. And now we're talking about a complete reversal of what we think is going on. Not only is there demyelination, particularly in the early stages, but there's also a cortical or surface involvement of the neurons. And we've come to a realization that we may be dealing with an actual neuronal disease that has this smoldering inflammation. That's a concept that we hadn't really thought of before, and I think it came across because we saw that no matter how well we did with medicines that controlled demyelination, people were still having deterioration later in the disease. And at first we said, well, it's just because we didn't catch them early enough, and there was a lot of demyelination, so that took its toll over time. But we're realizing that there's other factors going on. There's neuronal loss that occurs. And if you start looking at brain shrinkage or brain atrophy, it starts from the very beginning, even during the first stages, the first symptoms of CIS or isolated syndrome. So I think we realized that there's something going on that we just didn't realize at first. The other thing, we realized that inflammation is not inflammation, and not all inflammation is good, not all inflammation is bad. So inflammation is a part of the body that helps us to heal wounds. It works within the brain as well as outside the brain. And in MS, we realize that there's acute inflammation. We've known that for quite some time. So the immune system will attack nerves and cause acute inflammation that we see as spots on the brain and actual attacks within the person's experience with MS. But we're also seeing some chronic inflammation, some inflammation that's been there for decades and probably from the very beginning. And we're seeing that that may very well be responsible for some of the late decline that we're seeing. You'll hear terms of progression. We used to talk about progressive and non-progressive MS. We used a lot of different names that we'll talk about. But I think you realize that the inflammation can occur either during the time of a particular relapse. Damage can occur and people can be left with permanent deficits. It's called relapse-associated worsening, and that is a new term we're using more and more. But we're also now coming up with the term of attacks and progression that don't relate to specific attacks of the nervous system and what we call something called PIRA, P-I-R-A, for progression independent of relapse activity. So we're realizing that there's people who have progression and we don't understand all the things that are going on, but we know that there's more chronic inflammation within the brain. And so we talk about, we used to call it an outside-in disease where the immune system attack from the outside going into the brain. Then people started raising the issue of an inside out, where the inside, the nervous system itself is creating inflammation and also attracting from the outside cells to come in and attack certain areas. So our definition and our understanding has definitely changed drastically. You'll hear a term called smoldering MS, which is the term we're using for this more chronic active disease. And some of the newer MRI techniques are now allowing us to see what this looks like. So you'll see not only the white spots, but you'll see slowly expanding lesions that are found to be chronic active lesions, and that seems to be some of the more chronic progression. And then we're also seeing these areas around certain chronic areas of damaged areas, and there's magnetic rims, they call them paramagnetic rim areas or rim lesions, and those also seem to be a correlation with progression and seem to correlate with this smoldering type of process. So it's very interesting to see where we've come both by MRI and pathologically. The genetics are incredibly important. Whenever they've looked for genes, initially there were a few genes discovered. Now there's hundreds of genes. Some are responsible for susceptibility, meaning that your tendency to get the disease, and then certain aspects and what it would look like. And in the future, we may be able to outline genes that will predict which people are going to have a more aggressive course. So I think that's coming along quite dramatically. And then we've also seen some of the information about infections. And going back to my old days, we used to look at studies that looked at spinal fluid, and they would find measles viruses and all kinds of viruses that were in the autopsies of patients that had passed. And we said, oh, well, maybe it's a viral disease. And it doesn't appear to be quite that simple. It's clear that viruses such as Epstein-Barr make a big impact, and there may be some smoldering or more chronic effects of having the Epstein-Barr virus in certain susceptible people in certain cells of the immune system that are generating some of these attacks. And they may be looking at ways of trying to impact that in the future. You've also heard about people who have had post-infectious diseases. So people who have been through viruses such as COVID and other viruses that have the initial symptoms of a virus, but then 2 to 3 weeks later start to come down with a neurologic issue such as transverse myelitis or encephalomyelitis or things involving the brain. So we know that the viruses play a role, but we don't think that's the causatory role. We just think it's a contributory role. Now, getting into the diagnosis has always been interesting because back in the day, we would rely on basically back in the 70s and 80s, early 80s, we would rely on the patient's history, and the history could be terrific. They could remember pretty dramatic attacks going on from early on, but a lot of time people would just minimize the symptoms, or the physician that they told the symptoms to would minimize it and didn't think much of it. So we don't always get that history of early attacks. So it's important to try to piece together some of those factors in the history. It's interesting that some people will relay a history of when they're exercising, particularly for prolonged periods of time, or when they're out in the heat. They start to develop worsening of some of their symptoms. And these can be something like an visual loss, or it can be a foot drop. And in fact, that's named after a German neuro-ophthalmologist named Wilhelm Uthoff, who described this way back, I believe, in the 1800s, talking about how exercise or heat exposure can bring out certain neurologic deficits. And so given that, we said, okay, someone comes into the office, they look like they're perfectly normal, they're not having any symptoms now, but they describe certain symptoms that they were having weeks or months ago. And we would take them, put them into a hot bath test, raise their body temperature to 102, and we'd watch some of these neurologic deficits appear right before our eyes. It was just an incredible phenomenon. And I actually watched that at the University of Miami during medical school. They demonstrated that, and the person developed double vision. You could see the eyes changing. So it was a terrific tool because we didn't have MRIs back then. The problem is that not everybody, when they cooled down, would return to their normal state. And so we had to pretty much abandon that interesting test. But it is helpful to take a history and know that those things can make a big difference. The examination can be very helpful if the person has some permanent deficits. So if they didn't have a complete recovery, or you're catching them during the acute phase of the attack, you can actually demonstrate things on their examination. So the physical exam is very helpful in helping us to establish the diagnosis. And then we get into testing. So part of the testing is done to exclude other things that may look like MS, or what we call MS mimics. So we might do blood tests to look for things like lupus, or Sjogren's syndrome, or other conditions that may have similarities. And they can be very similar. They can mimic one another. The old disease, syphilis, that we don't see nearly as much, used to be called the great mimicker, because that would actually look like a lot of different neurologic diseases. And in MS, that was also commonly seen, less so recently. So we do tests to try to exclude those kinds of things. The MRI can be helpful for looking at certain degenerations in the nervous system, everything from Parkinson or Parkinson-like syndromes to ALS to primary lateral sclerosis, all these different conditions that may look a lot like MS and act like MS, but are not. So we have to exclude some of those things. And then, of course, we use the MRI, and we'll talk about the MRI criteria in a moment. We use spinal fluid examinations, which can be very helpful, and we use evoked potentials and things of that sort. There's also a new blood test called the serum neurofilament light that can provide some clues as to whether there's demyelination or active damage to the nervous system. It's not a very specific test because it can be seen in other things like traumatic encephalopathy and ALS and other conditions. So then we get into the criteria that were developed to help us diagnose MS. So the original criteria were developed back in 1965 with Schumacher, and that was primarily just a clinical diagnosis. So one of the prerequisites was that you had to have different parts of the nervous system affected, and you had to have different time frames to compare. It couldn't be just a one-time thing. And so that was helpful. And then when the MRI started to show lesions that we could identify as MS in 81, 82, in 1983, Poser came out with additional criteria that looked not only at the clinical criteria, but also the MRI criteria, and looking at ways of telling different parts of the nervous system and also being able to tell in different time frames. And then the most helpful and the most advanced criteria in MRI has been the McDonald criteria beginning in 2001 and extending now to 2024 when they're just starting to talk about, and we'll be continuing to talk more about some of those criteria. And the whole point is to be able to use an MRI, but you can't just take the MRI in isolation. You have to have someone who has a symptom that can seem like MS. You can't just take anybody off the street and expect the MRI is going to be very helpful. But if you have someone who comes in with their first clinical attack, whether it's optic neuritis or transverse myelitis or stroke-like episodes, brainstem episodes, then you can take that person, put them through the MRI, and be able to tell whether they meet criteria for MS. So you're looking for dissemination or differences in different parts of the nervous system. Can anybody name the 5 main areas that we look for? Okay, so with me now, just repeat after me. So you have what's called juxtacortical, which is next to the cortex. You have periventricular or callosal, which is around the corpus callosum and the ventricular system. You have the infratentorial, which is the area of the brainstem and cerebellum. You have the optic nerve, which was recently put in as a criteria. For some reason, there was some hesitancy before. And then the 5th one is the spinal cord. So if you have people who have those different areas involved, and it takes at least 2 of those 5 areas, then that can meet the criteria for dissemination in space. To meet dissemination in time, there's a couple ways to do that. One is to see if there are both old and new lesions on the MRI. So you can look at an MRI and say, oh, well, this one's clearly old because it doesn't enhance with the dye, or it's got a black hole formation. And then you look at another one that looks brand new because it's larger, it's enhancing with the dye. Then you've got 2 different lesions that are at different points in time. So you know one's new and one's old, and you can meet that criteria immediately for time. If you don't have those kinds of changes, you can either repeat the scan again, anywhere from a month to 3 months or 6 months, and see if there's any new lesions that develop, or you can do a more rapid test by doing the MRI first, doing a spinal fluid exam, and if the spinal fluid is abnormal with oligoclonal bands, and now there's other tests called kappa-free light chains and so forth, that those things now can give you a diagnosis of MS. So it's very helpful. I think you get into trouble when you start to try to make a diagnosis in someone who's older, particularly past age 50 or 60, because they typically will have white spots normally, and you have to try to differentiate whether they're typical for MS or more in line with the aging, particularly if someone has risk factors for vascular disease, high blood pressure, diabetes, hypercholesterol. Those tend to produce more abnormalities on their MRIs, and it's more difficult to determine. And those are a little trickier, and you may have to have the enhancing lesions. You may have to have you might have to have spinal cord lesions, and then also involve the spinal fluid. There's a spectrum that I like to talk about. Everything's on the spectrum, right? The spectrum for MS starts with a benign process. So something that the person never had any symptoms, or no one discovered that they had any symptoms, or no one really addressed it, but they died of a ripe old age, and they had an autopsy for whatever reason, and they found spots that look exactly like MS. So that's what we would call the autopsy-proven benign form of MS. And then you start to move to the next level. You have someone who never had any symptoms, but their MRI showed they did an MRI for another reason, let's say for head trauma or migraines or other things, and they did an MRI, and they found spots that look just like the spots we're seeing in MS. And so those people would meet what we'd call the definition of RIS, which is radiographically isolated syndrome. And those people do have a higher risk of going on to develop MS down the road. And it's particularly the case if they have spinal cord involvement, or if you're following them over time and they're starting to accumulate lesions, their chance of developing more definitive MS and disability is much higher. Then you get into MS that's relatively mild. So at some point you may have had a few relapses, and you're not having relapses now, you're not having progression. So you're basically MS without activity or without progression. So that's still considered a relatively benign form. The problem being that you can't predict that early on. You only can look back over 30 or 40 years and say that person had benign MS because they didn't develop any lesions, because lesions can develop at a later time. And then you get people with relapses, active relapses, but no progression, active relapses with progression related to the relapse, so relapse-associated worsening. Then you get into the person who's having no relapses, but they're progressing even without relapses. That's the PIRA, or progression independent of relapse activity. And then you get into some of the other things that may occur, like normal aging can produce some deficits that we all see. So as we're getting into our 70s and 80s, we're starting to have more difficulty with walking normally. And so we have to take that into account as well. There's a more aggressive couple of forms of MS. One's called tumefactive MS, and it's aggressive in the form that when you do an MRI with their first attack or one of their attacks, the MRI shows what looks like a brain tumor because it's very big and very swollen and enhancing. And so that sometimes the only way to make that diagnosis of MS is to do a biopsy. And the good news is that when you follow those patients, a lot of them don't have second attacks, but you still have to follow them like anyone. And then the worst variant would be the Marburg variant, which is a very aggressive form of MS that can lead to severe disability and death. And thank goodness I've only had the opportunity of seeing that one time. A patient in the hospital I saw in consultation had symptoms, mild symptoms for a couple of years, but then in the preceding month or two was deteriorating very rapidly and was bedridden and barely responsive. So we do have some people that are in very aggressive forms like that. Okay. So one of the things I should mention is we have to deal as neurologists and patients with uncertainty. And uncertainty can be about the diagnosis because there's no 100% foolproof way to make the diagnosis unless you have all things line up. And you also have to deal with uncertainty about, how someone's going to do in the future, their prognosis. There's an excellent review of uncertainty by Gavin Giovanni from the UK, who in his blog called MS Selfie had an excellent review of uncertainty. And it's very enlightening. If you ever get a chance to read that, I would encourage you to look into it. Okay. So now we're going to talk a little bit about the prognosis. Excuse me. So prognosis means, how someone's going to do in the future with or without treatment. It doesn't address specifically the treatment. And there's a lot of factors that tend to predict whether someone's going to have a stormier course. And there's a lot of them. And they're not all foolproof. They give kind of an indication, but in and of themselves, one or two of these different risk factors do not necessarily predict reliably that the person's going to definitely do worse. But it is something that helps guide our treatment. If someone is showing signs of having worse prognostic factors, then we might push them towards a more aggressive form of treatment, or at least to start treatment. Male gender is a risk factor. Men tend to have the disease less often, but when they do get it, they tend to have a stormier course. It's not 100%, but it is statistically shown. People who develop their symptoms after age 50, people who are of non-European descent, so people of African descent, African American, African and Asian, tend to have more, or Asian, tend to have more aggressive forms of the disease. If your relapses are more frequent in the first year, or if they're close together, or if you're not developing full recovery between relapses, that's a significant problem. If the symptoms are multi-systemic, meaning that multiple areas are affected, vision and coordination and gait and sensation and motor, if you have multiple involvement, that tends to be a worse prognosis. People with primary progressive MS tend to have it at a later age than most, and it may be that we're just picking those patients up at a later time, and so they're more progressed and didn't have as much of a warning ahead of time, so they didn't have as early treatment. MRIs that show multiple lesions, particularly in that infratentorial area, that can be a limited prognosis. If you have cognitive impairment early on, that can be a factor. Family history to some extent, spinal fluid with oligoklonal bands. And then there's a whole bunch of comorbid conditions that have been looked at as being contributing to a worse prognosis. So people with high blood pressure, diabetes, high cholesterol, obesity, cigarette smoking. When people have looked at those in studies, there is a higher risk of developing disability with these various factors. Even things like your diet may be playing a role, and it's exercise and lack of thereof. So that's important, as Jeff had mentioned, to keep up with those kinds of things. Even depression and bipolar disorder, people who are socially isolated or low income may have a worse prognosis. If you've been on a DMT and you fail it, not so much because of side effects, but because of lack of benefit, that may be a reason why prognosis would be worse. All right, let's kick right into management. And we're going to talk really about the different forms of management, not necessarily individually drugs, unless you want to discuss that during Q&A. But the first thing to think of is the acute phase. So the traditional way of treating MS is with steroids, either orally or intravenously. And back when I was going through my first years of residency and getting into first years of practice, we had nothing for probably over 10 years except steroids. And they were great at controlling individual attacks, but people were still deteriorating, people were still coming in with disability. So it wasn't something that actually treated the underlying disease, so we had to look for other things. We could treat the individual symptoms, everything from neuropathic pain, fatigue, bladder and bowel symptoms, spasticity, and so forth. So you can treat the individual symptoms, which is not separate from, but along with the other types of treatment. We talked about lifestyle changes, high blood pressure, diabetes, cholesterol, and so forth. Introducing physical and occupational therapy, speech therapy. You can do things now online, but it's probably better if you can find someone that you can rely upon locally to work with one-on-one. And if for those of you who are so inclined, personal trainers can be very helpful to work with you as well. And we can't forget brain exercise. We talk about physical exercise, but sometimes we forget about exercising the brain. So you want to keep up with things like puzzles, and we do puzzles. It's our tradition during the holidays to do 1,000-piece, 500-piece puzzles, which drives me crazy after a while, but it's good for my right brain. And you can do crossword puzzles, which is for left brain. So there's a number of things. There's some online apps that are excellent. One is called Brain HQ. So a number of things can be helpful. And there's different workbooks that you can do to exercise the brain as well. One of the things that doesn't get discussed enough is trying to disconnect. And what I mean by that is that people are so caught up in media and electronics and hustle and bustle, and we never have a chance to sit back and say, okay, let's take a break. Every day you should just disconnect for 10, 15 minutes, half hour. You can do some meditation. You can do something called yoga nidra, which is a relaxation technique. You can get outdoors and be exposed to nature. All these are ways of trying to rest your brain and give it a little bit of a break. It's been shown that just doing some of these meditation techniques may actually help you learn new information and help rest the brain and be able to energize you for later in the day. And people like Thomas Edison and Einstein were famous for doing power naps and napping during the day. And when they finished their naps, they would go and do some of their best work, reportedly. So there's something to be said for disconnecting a little bit. And then you get into the disease-modifying therapies. And the choice of going on to the DMTs is sometimes a difficult one. Sometimes we may not do one at all because, we're ready to start families and we don't want to introduce anything that would harm the baby. We may feel that someone's too advanced and too far along to be able to treat, or they're too elderly. People into their 80s and 90s have a higher risk of complications. So there is a role for not treating with DMTs. And there's also a role for discontinuing treatment. So if someone's been perfectly stable, they've had the disease for decades, particularly, they haven't had any activity for over 5 years, and they've done really well, there could be a role for coming off of medicines. Now, this is very popular with the insurance companies, but oftentimes is the way we introduce those kinds of drug holidays to take people off. But you do have to watch people very closely, monitor very closely, and make sure that they're not developing other activity that you have to treat more aggressively. When we only had a few medications available to us, we would use those what we call platform therapies. So you'd use Copaxone and Betaseron and Rebif and Avonex and some of the original injectables. And then as time went on, there were more and more therapies that came along, which has been incredible with regard to the research. And they started to compare. Originally, they did just placebo trials, but then they started comparing new drugs with old drugs and found that there clearly was benefits to going with some of these newer, higher efficacy drugs. So people started to move towards going from low efficacy to higher efficacy. If you waited too long to eventually get to the higher efficacy drugs, there was a window of opportunity that was lost, and people would develop increasing disabilities. So you may be able to stabilize them at some level, but their quality of life wasn't optimal. So now we're looking at, and there's been a trend towards going more towards the higher efficacy drugs. And there used to be a fear that higher efficacy drugs were necessarily going to be more toxic. But I think there's so much individual variation from person to person, and some of the higher efficacy drugs really aren't that toxic when you look at the whole scheme of things and compare it to MS without treatment, where 75% of people untreated within 10 years may not be able to walk independently. I mean, it really makes you think that maybe we should be starting with the higher efficacy therapies and then backing off later as we get older. A lot of this was taken from other specialties like rheumatology and cancer, where people would get treated with very high doses of medication, and then they would back down or they would go into a quieter phase. And in MS, it's shown to be very effective. Now, it's not right for everybody, and it's an individual choice, talking to your physicians, and that's something that is the art of medicine. But there's definitely a lot to be said for some of these higher efficacy drugs. And I'm a firm believer that just because it's higher efficacy doesn't mean it has to be toxic. Now, some of the original medicines like Cytoxan, good name, medicines like Novantrone, stem cell therapy and so forth, actually are very aggressive therapies and tend to be a little higher risk. And so people may shy away from some of those. But we still have plenty of other higher efficacy therapies, the B-cell therapies. We have Tysabri, we have Mavenclad, and a number of others, the S1Ps, and a number of therapies. So there are a number of drugs that can be higher efficacy for most people. So it's a matter of sitting down with your physician and finding out what the best approach is. What sometimes happens is people just absolutely don't want to have anything to do with anything that's the least bit risky, so they'll go with a milder therapy. And that's fine, and I don't necessarily disagree in principle, but I think we're changing. I think if someone decided to go with a lower efficacy therapy just to avoid side effects, and that was their adamant choice, then we do that. But you can check and monitor people very closely, every month or every 3 months for the first 6 months. And if people are not improving or are deteriorating, then you should really consider very rapidly moving to a higher efficacy therapy. So that gets us into monitoring. Monitoring is very important. You do it through the history of what the patient's telling you. You talk about side effects. You go through the examination. And now you're going to see more and more talk about what's called the MS stress test. You've heard about exercise stress tests, but there's something called the MS stress test, and that's going to be unique to MS, and that involves things like the timed 25-foot walk, the 9-hole peg test where you can measure fine motor control. There's the MSLT, which is a symbol modality test, which enables us to do cognitive testing. You can do more in-depth neuropsychological testing, which can help monitor your cognitive function over time. So all these things can be very helpful. There's a newer test called the serum neurofilament light that can also help tell whether someone's responding to the therapy or whether they're going to be prone to more activity down the road. So we're finding more and more that that's becoming a thing. And then I'll complete this by, I know Stuart's happy about that, talking about some of the things in the future. And there's nothing that's out yet, but we just had a presentation at ECTRIMS this past fall that talks about a generic medicine called tolebrutinib. It's one of the category of BTK inhibitors, and that showed some promise in people who had been progressive MS without relapses. And we've never had anything indicated for that particular indication. So we're hopeful that that class of drugs may be something we can start looking at for this more chronic smoldering MS and be able to keep the disease from progressing. And it may be that we're going to be using combination therapy in the not too distant future. We just have to all be advocates and talk to our legislatures and everybody that'll listen to us about the importance of making sure these medicines are available to us. You're going to be seeing things like the Epstein-Barr virus. There isn't so much a therapy, but they're going to be looking at vaccines in the not too distant future to try to catch people very early. So if they never get exposure to Epstein-Barr, maybe they will never get MS. And there's some viable reasons why that might be helpful. We haven't seen a lot of things yet with remyelination and nerve regeneration. There was some preliminary evidence of alpha lipoic acid being helpful for remyelination, at least different kinds of nerve impact. And then there actually was listening to a scientific study in rats that were fed some of the certain foods that, like kimchi and some of the sauerkraut and certain agents that seem to help with remyelination. So maybe that's an answer too. And it also goes to speak for the fact that the diet may be a lot more important than we've given it credit in the past. There are other things like metformin and some of the GLP-1s and NAD and a number of different compounds that are being looked at in the future. So all these things are hopefully going to be coming out this year and next. So stay tuned, and we should be able to add to our repertoire in the very near future. So I will open up for questions.
First, you have to let us say thank you.
You're very welcome.
So I'm going to ask again, does anybody have a question? That's great. While I'm getting to you first, since you raised your hand first, tell us about smoldering MS.
So smoldering MS is this thought to be due to cells within the central nervous system, the macrophages. So these are cells that actually work for inflammation, both good and bad. So there seems to be a shift in MS towards the bad side, the chronic inflammatory side. So it seems that may be responsible for some of this chronic inflammation that's occurring around some of the older cells. And that may be seen even as early as the onset of MS, but certainly may be a bigger factor as we're getting older. And as the acute inflammation dies down, then some of this smoldering component may be playing a bigger role. What's not clear to me is how often that's occurring, but clearly if you look at some of the studies, even the Ocrevus study that looked at treating patients, even though the patients had benefits with regard to relapses and disability and actually disability improvement, there was still a certain percentage of patients that were deteriorating slowly. And so there's a certain group of patients where this smoldering MS seems to be more of an issue. And that's where hopefully some of these newer agents will come to play.
So if a patient has new or worsening symptoms and they're already on a high efficacy treatment, such as Briumvi, for example, and they develop new or worsening lesions, new or worsening symptoms, is there ever a case where that patient is put on more than one high efficacy treatment, or are they just switched out of that and into another similar drug?
We used to use combination therapy, and people didn't find a lot of added benefit, and in some cases there was so much immune suppression that it became an issue. So what we tend to do now is try to find another class of drug or another mechanism of action that might work differently. So just because, let's say, a B-cell therapy might work one way and be beneficial for one person, that doesn't necessarily mean that genetically that person's going to benefit. So we have to look at another mechanism of action. So it might be something that would have to do with therapies that work on other cells, maybe work on some of the macrophages that we talked about. So it's a matter of looking at other options that way. Sometimes just adding other things, pulse steroids or even pulse IVIG for a period of time or plasmapheresis sometimes will work. It's just that the evidence for that is not great for long-term for most patients. But in individual cases, I've found those to be beneficial.
Are there particular diets or supplements that you would recommend to reduce inflammation? And also, what are your thoughts about the Walls diet?
About which?
Walls
diet. Okay. A diet has been very controversial. And I think people talk about, well, I don't want inflammation, so I'm going to do an anti-inflammatory diet. Well, inflammation, as we said, is both good and bad. But it's clear that if you look at some isolated research, for example, the Mediterranean diet is the one that's had the most behind it. And Mayo Clinic has a nice summary of that on their website. But if you look at the Mediterranean diet, which professes to use fresh fruits, vegetables, I said fish, fruits, vegetables, olive oil, nuts, hummus, that type of thing. Of course, there's a lot of Mediterranean countries around the Mediterranean, but they have some things that are in common. And that seems, when you look at studies, to have benefit. So, for example, in Alzheimer's, it's been shown to, and in stroke patients, has been shown to have some beneficial effects long term. So I tend to go with that. I think it's an easier diet to stick to than most. And it may be not any one thing like diet alone that's going to be the answer. It's probably a whole host of things. We've talked about exercise and watching your cholesterol. And I've even put people onto some of the statins with the idea that if you can lower your LDL cholesterol, then that may also have an impact. So I think a lot of those things have to be looked at in total, looking at the whole picture. Diet alone is a good endeavor, but I don't think in isolation is an issue. You just have to look at a lot of different factors. A lot of people tend to say, okay, well, I'll just follow the Wall's diet and I'll get just as good a result as she did. Well, I've had a number of patients try the Wall's diet and stuck to it pretty vigorously and haven't found any benefit. Again, they did do a study with the Wall's diet against, what was the other diet? Now I'm blanking on the other diet. And that didn't show any real differences between the two diets. So there's a lot of controversy about diet, but it's clear that the things that seem to be the most detrimental are high sugar, high cholesterol, particularly saturated fat. You want to try to be reasonable. You want to try to drink alcohol in moderation, eliminate smoking, and hydrating, and all the good things we talk about. So I think all those will make a difference. It's just not going to happen overnight, and it's not going to be easy, as we know. Anybody found all these things to be easy? It's just not.
Thank you. Next question's from online. Person says to ask you about brain volume loss and whether we can look at 5-year-old MRIs compared to today's MRIs and measure brain volume loss, or do brain volume loss calculations need to be made at the time MRI is performed?
Okay, I'm not sure if I understand the question completely, but looking at more advanced techniques for MRI is not widely available, particularly for atrophy and even the slowly expanding, the paramagnetic rim lesions are difficult to see on most routine studies. So I think if you have an interest in those kinds of studies, and it's probably better to go through a university that deals with 3 Tesla and 7 Tesla magnets. I think you get a better view of that from that standpoint. The problem is you have to be able to do that over time and compare it. So you have to do it sequentially.
Thank you. Have you any knowledge of the octave testing?
There's a group of tests that can be done that look at different factors. I haven't found them to be cost effective yet, or really haven't seen a lot of evidence that it's really helpful in making the decision. We can get the serum neurofilament light done either through any of the labs, Quest or LabCorp. It's not necessarily covered by insurance. I think it's somewhere in the neighborhood of $200 to $250. Most of the people I've done that with have been normal, so I don't know if it's just that they're on such good therapies or it may not be as sensitive as we would like. So,
Great, thank you. What can you tell us the difference in why a person should use a baclofen pill versus a baclofen pump?
Baclofen pills typically are very effective. They've been used for spasticity for a long time. Like anything with baclofen, you have to be careful about finding that therapeutic window. So if you go too low, you're going to get too much spasticity, too high, too little spasticity and floppiness and loss of function. The baclofen pump has been very useful in isolated patients. They're not done as often. We're not having as many people that are adept at doing them, at least in this county. But I think it can be very helpful for those people who have tried other oral agents and just haven't gotten the results that they like.
Telehealth. Do you practice telehealth?
I do.
And what would you tell your patients here or online that might be watching why you think telehealth is good?
Okay. Telehealth is invaluable for people who are not able to get out of their homes. I used to make house calls pretty regularly, and now we can do telehealth, so that works. It's still not as personal or as accurate as being there in person. And so house visits and in-office visits still should be done from time to time. I wouldn't use telehealth as an exclusive way of care unless someone just doesn't have the ability to travel to your facility. I think it's great for rural areas and so forth. But for my patients, we use it from time to time if they're sick or if they're not able to get to the office for whatever reason. I think it's a great interim step that keeps them in contact. And I think that that's invaluable.
Why are Asians less affected by MS than anybody else?
Why is what?
Why are Asians less affected by MS than other genres of people?
So the incidence of MS is higher in European descent. So that means people of in Europe as well as transplanted to northern United States and so forth. For some reason, probably because of genetic protection, they're not having as many. The incidence is not as high, but it may be there may be other factors as well. But why they get a more severe form of the disease is not completely clear. But I think there are likely genetic factors involved.
Okay. BTK inhibitors, have you spoken about that?
I mentioned tolobrutinib, BTK inhibitors. So that's an effect inside the macrophage, which is inside the central nervous system, and is thought to make a big difference in terms of chronic inflammation. So the BTK inhibitors are showing some promise for the more chronic phases. There have been at least one, maybe two studies now that have shown that it doesn't do much for relapse activity, but does do a lot for the more chronic phases. The problem with studies, you have to take everything with a grain of salt. So the ones that failed against another drug, which was teriflunomide or Aubagio. So would we consider, it's not like comparing it to placebo, and in fact now we consider it unethical to compare a drug for relapses against a placebo drug or placebo agent. So I think you have to look at everything carefully. It's no better or no worse than Aubagio, so it's still beneficial, but it's just not being used for that aspect and probably won't be released specifically for relapse activity.
Cogfog. What testing do you have for people who can't remember what they can't remember?
Well, if I have, usually it's the family that are the first to tell me that there's a problem and not so much the patient. But a lot of patients talk about cogfog as a common scenario, and at least 50% of people will mention that they're having some cognitive deficits. So it's very common. The problem with it is that you can't say, well, it's just MS. Because if you say it's just MS, then you're saying, well, that means my therapy has failed or you need to get on therapy. So the way I look at it is a whole broad approach and make sure that we've covered all the bases, looking at their sleep patterns, looking at other medicines that might be interfering with their ability to remember things. And I think you have to look at that whole process. Sometimes people have had attention deficit all their lives, and it just happens to be aggravated from their MS. And then we look back at that and say, well, maybe we should look back at treating it. We used to think that ADHD went away when we got to be adults, and that's just not true. They oftentimes are in MS patients who are having cogfog. So I think it's helpful to consider treating those kinds of ADHD situations. So, but it's a whole, in my opinion, it's a whole way of looking at things. You can't just say it's just the MS. Sleep is vitally important. I mean, we talk about, oh, well, I get plenty of sleep. Well, when you start to break it down, I'm getting up, 3 times a night to go to the bathroom. And yes, sometimes I can get back to sleep, but it takes me a while. And then people are going to sleep at midnight and getting up at 6 in the morning and only getting 6 hours if it's straight. So the studies have shown that 7 to 8 hours is ideal, but it depends on what your pattern has been throughout your life. Some people require a little less, some people a little more. There are some excellent programs that you can listen to, podcasts The Huberman Lab is one that I listen to frequently, and they've had a number of excellent podcasts about sleep. So I think that's a good resource.
Okay.
What do light chains tell you about MS?
Light chains for serum neurofilament light chains.
Kappa light chains from blood tests and things like that.
Well, the serum neurofilament light was also something that is used in Europe, but they also started with spinal fluid neurofilament light chains, and that has had some prognostic benefits. It's had some predictive value in terms of people that were more prone to develop problems with their MS, either particularly relapses. They were able to finally get it from the bloodstream through special techniques. And so now, at least in the United States, I'm not recommending spinal fluid examinations for every patient, thank goodness. But I think it does help to some extent. I still think that the history exam, the MS stress tests, and the MRIs are just still invaluable. I don't think those will ever go away. But those neurofilament lights are going to be helpful. They recently started talking about the kappa-free light chains in spinal fluid. Again, that may be helpful for diagnosis, but I'm not sure it's going to help us in any other circumstance.
Okay, going back to when you were saying about treatments for cognitive issues, what kind of treatments do you give, do, or otherwise?
Okay, so there's several situations. What I usually do is do the neuropsychological testing, take a careful history, try to eliminate the things that are easy to eliminate. So take away drugs like some of the benzodiazepines, Xanax, clonazepam, lorazepam, if the person's having cognitive issues, because they can make it worse. Eliminating Benadryl, which people tend to use to help them get to sleep, because that can impair their cognition. Even some of the other antihistamines can be an issue. So I try to eliminate the offending agents first, try to get a good baseline neuropsychological assessment. If there's attention deficit, I'll work on that. If there's an element of anxiety or depression, then I'll work on that separately. There have been occasional patients that have responded to some of the Alzheimer agents, off-label, things like Aricept or memantine. I find those very helpful for some individuals, and you can adjust the doses based on their need. So I use those freely if all the other factors have been eliminated as a cause.
Okay, thank you. Next is, person is writing, can hyperinflated lungs be a symptom of progressive MS? If so, how are they treated in MS?
Hyperinflated lungs? So I'm not aware that that's an issue. Now, what commonly can occur in very advanced MS is that people can develop scoliosis so severe that it starts to interfere with their breathing and clearing of secretions. And sometimes they have to use special devices to help them cough. You want to use bracing to try to improve their posture and get to where they can breathe more effectively. So I think it really depends on the specific circumstances. I'm not aware specifically that hyperinflated lungs has been associated with that. But
Thank you. Next big question, is it age or is it MS? How do you differentiate the two with an older society coming in for their appointments?
that's an excellent point. One of the interesting things I found was there was a report about autopsy specimens in people who had cognitive impairment and MS, and they actually found a lower incidence of the tangles and plaques that you see with Alzheimer's. So there actually seemed to be a lower incidence of Alzheimer's. That doesn't mean that you can't have Alzheimer's along with MS, but it seems to be less likely. I've seen some individuals have such severe cognitive impairment that it looks all the world like an MS patient. I think whenever we're getting to our older ages, and I can vouch for that, we're always looking at what things are going wrong instead of what's going right. And, it's the aches and pains, it's the balance. There's a number of things that are just part of the territory. And we're only in the last few years have the therapists now educated us about how to keep in a more healthy venue, how to prevent from falling, how to improve our trunk strength. One of the leading causes of death in the elderly population is falling and breaking a hip. So it's clear that we have to find ways of improving balance. I have to give people tools on what they can do to improve their trunk, and I think that's vitally important. Cognitive is always something that's all on our minds. We always worry about, we go into a room and forgot why we went there, or we have a name of a person that we can't remember, or trouble finding words. I mean, we all have that as part of the normal aging process. So we have to constantly be vigilant of when that's starting to accelerate and fall away from normal. And if you're not certain, other than asking your spouse, which may or may not be reliable, because they may have as many problems as you do, but you definitely want to have it tested and looked into. And the psychologists, neuropsychologists are very good at helping us to determine which things are within the normal range, whether their factors might be playing a role. Sleep in the elderly is critical. I mean, we used to say that elderly patients didn't need as much sleep. That's a misnomer. That's completely false. And the problem is that they don't get enough sleep because they're not sleeping as soundly. There's more interrupted sleep. Their sleep architecture is impaired. And so you have to look just like anyone else. You sit down with all the basics of sleep hygiene. You want to get to sleep at a reasonable hour. Try to give yourself, shoot for 8 hours. When you get up in the morning and start to get up and move about, get out in the sun, try to get active, try to eat a light snack, even if you're not inclined. But all these things will help to improve your sleep-wake cycle. So it's vitally important at any age, but particularly in elderly, to start looking at those things. There are reports about Alzheimer's patients having more trouble with their sleep. And the question is it the chicken or the egg? And I think it's a big part of it is their sleep and lack of activity and social isolation that's driving the problem. And once you start to reverse a lot of those things, put them on the Mediterranean diet, do aerobic and resistance exercises, you can actually stabilize those patients and keep them from progressing from a mild cognitive impairment to a full-blown Alzheimer's patient. So there's a lot to be said for those kinds of basics all the way around.
Next one from Miami. Wants to know, is Prolia for osteoporosis contraindicated for MS patients?
I am not aware that it is.
Okay. From Greenland. Okay. She's on a lot of our programs. Wants to know if there is still the same truth that MS affects those from the northern latitudes more than the southern, because she sees a lot of our programs in Florida and doesn't understand why there are so many people with MS in Florida.
They're all transplants.
That's what I tell her.
They're all from Greenland and Northeast. No, I think there's no question that we've found this north-south and the latitude making a huge difference. A lot of it has to do with when you leave the northern latitudes to come south. So under age 15 seems to have a lower incidence. If you wait till after age 15, there's a higher incidence of MS in the northern latitudes. But part of that may be sunshine, part of that may be Northern European descent. So it's really hard to know exactly what the cause of it is, but there's probably a number of factors, genetic and otherwise.
By the way, she also says she does not want to become part of the United States.
And I'm not pushing her that.
All right. Next, do you know anything about CAR T cellular therapy research for multiple sclerosis?
I know that it's being studied. It looks promising, but I can't give you any real results of anything yet. But that's something that's going to be a hot topic in coming months. In 1 month, 6 weeks, I'll be at the ACTRIMS meeting in West Palm Beach, and I'll probably hear about that.
Prior to you going there will be a video released that I did at the Bristol Myers headquarters back in November, where we interviewed the researchers from CAR T therapy, and it was just compliance approved yesterday for release in mid to end of February.
Great. Now you tell me.
Yeah, I could tell you about it. All right, you're the doctor, though. So any other questions? Thank you, and thank you.
I have a poor short-term memory, but I have an excellent long-term memory. Can you just explain that to me?
Oh, probably not. No, most
I can't remember.
most MS deficits tend to be short-term. It's the laying down of the newer memories that are more defective. Longer-term memories are more ingrained, so those came back from before you had MS. So it seems the reason that those areas are going to be more permanent.
All right, this person is next.
Is Kesimpta a high efficacy of medication?
Yes.
You've seen really good results in it. Have you?
I have personally seen good results, yes.
Well, the memory clinic, you sent me to the memory clinic, and they said I had 2 strokes. Like they looked at my MRI.
He's not allowed to answer that right now. He's not allowed to answer you this right now because you're his patient, and he's not allowed to disclose anything about you to everybody else.
Yeah, but I will bring up a general topic, which when you look at an MRI, sometimes MRI plaques, MS plaques, can look like a lot of other pathology. So it can look like strokes, it can look like tumors, it can look like abscesses. I had a gentleman, probably about 15, 20 years now, who came in, referred to me because he had multiple enhancing lesions in the brain. And he said, oh, he must have metastatic disease. I said, I don't think so. And I was looking at his gait, and he had an abnormal gait that didn't seem to correspond with what we were seeing in the brain. And so I recommended a biopsy of one of the lesions, and they were demyelinating or MS. So I think these things can all look alike. That's where we get into that uncertainty factor about diagnosis. You really have to think of a lot of different things. You can't just jump to the conclusion of one thing or the other. And I'll give you another anecdote. I had a patient who was treated for MS for 2-3 years, came to me for a second opinion, was on high efficacy therapy. In fact, I think she was on either Cytoxan or one of the higher agents, and she kept getting worse. I go, this doesn't sound at all like MS. So there's something about the examination that didn't seem right. Their reflexes were diminished in certain areas. It just didn't make sense. And I saw a few muscle twitches, or what we call fasciculations. And I sent the patient for an EMG. Actually, I did the EMG. And we found fasciculations through multiple muscle groups and made a diagnosis of ALS. And we took her off of the chemotherapy, and the disease continued to progress. This was before any of the therapies were available. There are a number of therapies that are starting to slow the rate of disease. And within, I think, 18 months, she had passed. So we have to look at a lot of different things. I've had patients with slipped discs. For example, a woman came in, had MS for 30 years, and she started having trouble with weakness in her legs. And she wanted to know what she could do for her MS. So, well, the first thing we have to do is get an MRI. And she had a huge disc pressing on her spinal cord in the thoracic area, sent her to a surgeon, and the weakness went away. So there are some good examples of why you can't jump to conclusions. These things are not necessarily diagnostic, and that's why we have these criteria in place, is so we minimize our mistakes in making the diagnosis and don't jump into the conclusion of calling something that's not MS, MS, and vice versa.
Can you address migraine and MS and how they would differ on an MRI?
Okay, well, there's a couple of interesting things about migraine. Oh, and remind me to talk about MS prodrome. So about 40% of MS patients will have migraine. Okay, about 10% of migraine patients will have MS. And so there's a close correlation. We don't know all the reasons why that is the case, but it is clear. And oftentimes you can see some of those things even before patients develop their first attacks. If you start looking at the MRIs, people have called migraine lesions MS. And so they look similar, but there are significant differences. The migraine lesions tend to be what we call nonspecific or more vascular-like. And so you can see them scattered in different areas through the white matter, but they aren't in those 5 big areas we talked about. What were they? Optic nerve, periventricular, juxtacortical, infratentorial, spinal cord. Did I leave any out? Okay. So that's what's so amazing about MS. You can look at a scan, and if it just shows nonspecific white matter changes, you can't tell if they have MS or something else. And most of the time it turns out to be something else. But if they have those typical features of what we see in MS, then it's very specific and it gives you a heads up as to what might be causing it. But migraine can produce some unusual things. It can even produce strokes. So you have to look at that. And migraine is a risk factor for stroke. It's uncommon. And it's usually in people who have other risk factors or cigarette smoking and so forth, birth control pills. So MS prodrome is interesting. We're talking about trying to diagnose MS at the very earliest stages and cure it. Okay, so we're talking about how do you determine if someone has MS before they develop either a new lesion or they develop their first attack. And you look at family history to some extent, but those people who have migraine, seizures, people with, actually I should look at my list. If I even have it. It's just fascinating because this is something that's a hot topic in a lot of the meetings now. People with fatigue, psychiatric disorders, bipolar disorders, urinary difficulties, cognitive impairment. So all those things may be an indicator that people are going to be prone, but you can't make a diagnosis based on just that. So you have to look at those patients, and if they have a family history, if it's coming out of the blue and there's not really a good explanation for it, it may be worthwhile obtaining an MRI one time to see if there's any lesions that might look that way. And if you can pick them up at the very earliest stages and treat them, there may come a time where we'll have a treatment that wipes it out. And there are some people who get very early stem cell therapy or chemotherapy that stop having attacks, stop having progression, and those patients have been essentially cured. Unfortunately, we don't get to patients rapidly enough, and we don't always have as high an efficacy therapy or some of these other things that work on the smoldering MS to be able to impact it long term.
Thank you. Everybody say thank you. Thank you. Awesome. So again, thank you everybody for coming here tonight. Make sure you drive carefully driving home, all right? And we'll see you all the next time. Thank you.